Assalamu alaikum. We will begin with the lectures in kidney, and today we will study the systemic disorders like Hematogenous purpura, amyloidosis, SLE that affect the kidney secondarily, and how we don't care about the kidney is when there are systemic diseases that go uncontrolled and eventually they take our kidney away. And among them is even sickle cell disease, multiple sickle cell crisis takes away kidney by causing many minor traumas, or you can say hemorrhages here and there in the kidney. When there are multiple microfocal hemorrhages or microfocal necrosis in the kidney, eventually the kidney dies and it goes into renal failure. And then we are going to see what kind, and we are going to see the interstitial nephritis, chronic glomerulonephritis, interstitial nephritis, and renal tumors, right? Renal tumors. Those are all of those topics are there on your UHS examination, on your test, in your vivas. And believe me, these glomerulonephritis are quite painful to memorize. What I would advise you is when you open your book, there is a table that talks about morphological changes, immunological changes, and electron microscopic changes for each of the primary glomerulonephritis. Memorize that by heart, and that will help you a lot, right? Before you go into any detail, memorize that chart and then start reading the rest of the chapter. I'll see if there is any time I will revise the things with you, glomerulonephritis, how to diagnose and go about things in reality and in scenarios as well. So now let us begin with the Hematogenous purpura. We talked about it yesterday. Hematogenous purpura, though it is a vascular disease, but it has much to do with the immunological deposits of IgA, right? So it has a picture just the same, similar or just the same as IgA nephropathy. IgA nephropathy is called as Berger's disease. यार हैमबर्गर तो खाते पीते रहते हो, उतना तो याद है कि हैमबर्गर and IgA nephropathy are one and the same disease. And they are nephritic syndromes. उसके साथ पेप्सी भी पीते हो, so cola colored urine is there, right? And in IgA nephropathy, what is very special, where do immune deposits are seen? Where are immune deposits seen? क्या हो गया है? In the mesangium. Immune deposits are there in the mesangium. Hematogenous purpura, IgA nephropathy, and they are manifestations of the same disease, right? In IgA nephropathy alone, when it is nephropathy alone, IgA nephropathy alone, we don't talk about the skin lesions. We talk about the kidney diseases, kidney disease alone. But when we talk about Hematogenous purpura, we talk about the skin lesions, and then there are kidney lesions as well. The age is same in both the cases, 3 to 5 years of age. Adults are more badly, severely affected, and it is accompanied by other allergic reactions in the body like atopy, falling upper respiratory tract infection. IgA is deposited in the mesangium, glomerular mesangium. Morphology is variable for IgA nephropathy and for Hematogenous purpura. There is no difference in morphology. Is variable. Mesangial proliferation, diffuse mesangial proliferation. It could be focal or diffuse, whatever, but there is mesangial proliferation. Talk about Mesangial proliferation, good enough to say it is either Hematogenous or IgA. They're one and the same things. And it could be diffuse or mesangial, doesn't matter. Since that burger disease and Coca-Cola and that cola progresses or has a tendency to progress to Crescent Pteroglomerulonephritis, which is crescent formation or proliferation of the parietal layer of Bowman's capsule. Parietal layer of Bowman's capsule, whenever it proliferates, it forms a crescent, आधा चांद बना लेते हैं. And this crescent, why is it significant? It obliterates the urinary space, creating oliguria. Yes, it causes oliguria, eventually hypertension and nephritic syndrome, right? Endocapillary to crescentic glomerulonephritis. These are the variable pictures. It could be focal mesangial, diffuse mesangial, and then it can produce crescents in the Bowman capsule, which is crescentic glomerulonephritis. This is glomerulus, and here you can see proliferation of the parietal epithelial layer, parietal segment. See, you see a stalk entering there. All right. Endocapillary proliferation is this. That means epithelial cell proliferation. Inflammatory cells have poured in, which means lymphocytes. If you see uh, with a little concentration, you will notice there are no lobules, small cells with little cytoplasm around them, and that is lymphocytes. Inflammatory cells and decreased capillary lumina. When the crescents are formed, they will push the capillaries, or they will obliterate the capillary lumen, and this will decrease the capillary filtration. Do we have a crescent formation here? No. There is just, you can see multiple lobules are formed because of increased mesangial proliferation. And mesangial proliferation is here and here, right? Most of the mesangial proliferation is here, and this is focal proliferation of glomeruli. Mesangial proliferation here, a little bit of there, but it is not a global proliferation. Crescent formation, and that causes rapidly progressive glomerulonephritis that kills in weeks and months. What is so special about rapidly progressive glomerulonephritis? It kills in weeks and months, and there are about 3 types of RPGN, and each RPGN is got diseases that cause nephritic syndrome, right? Nephrotic convert to nephritic and then RPGN. Otherwise, these are purely nephritic diseases that cause RPGN. This is a beautiful crescent, right? And it has compressed the capillary loops, and long stands, I told you, long stands, they are fibrin. Actually, whenever we want to show you fibrin, long thread-like stands are made into that area. Crescents obliterating the glomerular space, right? These are normal tubules. Skin lesion, subepithelial hemorrhages are there. Necrotizing vasculitis involving small vessels and the dermis. Subepithelial hemorrhages, yes, subepidermal hemorrhages, you have seen those subepidermal hemorrhages. That there is necrotizing vasculitis of the small vessels of the dermis. Look at this area of focal inflammation. This is skin, right? Squamous epithelium, keratin, and the basal layer of the cells. This is the dermis. This is the subcutaneous tissue. In the subcutaneous tissue, you see focal accumulation of inflammatory cells. If you focus on those cells, you will realize they are lymphocytes, or they do not have lobes, again small, they are cells with a peripheral rim of cytoplasm, round nuclei with a peripheral lymph of, with a peripheral rim of cytoplasm. They have blood vessels in between them, and therefore they are perivascular inflammatory infiltrate. Focal fibrinoid necrosis of the vessel. Can you see this? The vessels are actually not visible. All what is visible is pink areas. These pink area is fibrosis. Fibrosis was caused after necrosis of the blood vessels. All right, so purpuric skin lesion involves extensive surfaces of arms and legs. You can see extensive surfaces of upper and lower limbs. That is good enough. Purpuric lesion involves extensive surface of upper and lower limbs, or both the limbs. And abdominal manifestation includes pain, vomiting, and intestinal bleeding. So there is bleeding from under the skin, and there is all the right for bleeding to occur in intestinal lining as well. Non-migratory arthralgia. Non-migratory arthralgia means something went wrong in the joints. And what went wrong in the joints? Hemorrhages. What went wrong? Hemorrhages. And then there are renal abnormalities. So in Hematogenous purpura, we have skin involvement, we have intestinal involvement, and we have the joint involvement and the kidney involvement, right? So it is the skin involvement, and it involves extensive surface of arms and legs as well as the buttocks. So that is the upper and lower limbs. Look at this diagram. This beautifully explains. This one is a kidney. So it involves the kidney. And this one is the intestine that is weeping blood out. When intestine weeps blood out, that means there is, what is there? Could be two things. Melina, right? You have studied gastrointestinal tract, so I take it as you know the gastrointestinal tract very well. So when there is blood going out from the intestinal tract, we call that as melena. So there is abdominal pain. Look at him, abdominal pain, and then there is melena. The intestine is weeping blood, and the skin has all the purpuric rashes. The skin of upper and lower limb undergo purpuric rashes. I think this diagram is good enough for you to understand in a glance what went wrong and which organs are involved with what is going on. So we said skin, kidney, intestine, and the joints. You can see here there is pain in the joints, arthritis, right? And the joints, so it is, he has arthritis as well. I think this is a recording for you, so you can just keep this diagram, and I think it is better to get a printout of this diagram and just paste it on your book whenever it is Hematogenous. You will know it is IgA nephropathy. IgA nephropathy has mesangial deposits, and that may progress to RPGN. All right, gross or microscopic hematuria, nephritic or nephritic syndrome, or it could be nephrotic, but it is usually nephritic syndrome. Even if it is nephrotic, it can easily progress to nephritic. Clinical course variable. Again, hematuria persists for many years after the onset. Children, they respond well. Diffuse lesions that are crescenteric or nephrotic syndrome, poor prognosis. That is very sad. So IgA nephropathy Hematogenous purpura, we end up in poor prognosis. What is this? Fibrin stands. I told you threads. Look at the threads. Fibrin stands. Then there are tiny little dots. Whenever there are tiny little dot, it shows some kind of proteins or some kind of plasma proteins there. And then he has tried to make irregular sort of something here. This irregular thing is cells, usually inflammatory cells. So this is what is present in the urinary space or below the Bowman's capsule. All of this will irritate the Bowman's capsule and cause proliferation, causing Crescent Pteroglomerulonephritis. There is an RBC. So the kidney will start weeping. This is the actual histology. A big crescent is there. A big crescent is there compressing on the glomerular tufts. Bacterial endocarditis. In the very beginning, we studied the first thing we studied, first disease we studied was post-streptococcal glomerulonephritis. You remember, I know you remember. Post-streptococcal glomerulonephritis, I asked you what other disease it would cause immunologically, and you answered right, that was bacterial endocarditis, right? And that have got, both of them have a strong association. Bacterial endocarditis and glomerulonephritis, both are autoimmune disease, and these immune complexes are initiated because of the bacterial antigen, and the body starts forming antibodies against itself. Can you understand, a bacteria just comes out, comes into the body from outside and triggers autoimmunity against such vital organs in the body? It is just like a person, like one of your class fellows or your teachers or whoever known to you enters the classroom, kills by the gun a few students, and he leaves. Or one of us comes into the class, teach you, and then leave, and then we come again, and then we shoot a few students and leave. And then when we come again third time, you will definitely catch us as culprit, even though the person who was shooting was not the same as that coming back into the class. So if antigen resembles body organ or any antibody of the self region, it will become an antigen for that particular disease. What I mean to say is, if the body organ resembles an antigen coming from outside the body, it will definitely initiate an immune reaction against itself. So this is what happens when bacterial antigen causes endocarditis and glomerulonephritis. They induce antibodies because these antibodies start recognizing the antibodies on the heart and kidney as foreign. There again goes the same diagram. When there are antibodies, they're coming out into the coming out of the blood vessels into the GBM, and then they lie subendothelially, and they cause membrane attack complex. Hematuria, proteinuria, acute nephritic syndrome, right? This was a nephritic syndrome. It causes proteinuria and nephritic syndrome. Oliguria, urine less than 400 ml per day. Hematuria, blood in the urine, could be microscopic or macroscopic. Mild proteinuria and edema. Mild proteinuria and edema, right? Hypertension and azotemia. So by the end of the lectures in kidney, you must be able to recognize nephritic, nephrotic syndromes, rapidly progressive glomerulonephritis, and then which disease was the causative agent, or what to treat. Once you have diagnosed the disease, there is a whole panel of antigen, of immunofluorescence that we do, immunofluorescence against IgA, IgM, IgG, and then C1q, right? And then we diagnose which disease it was. And once the disease is then identified, then we look into, is it a primary disease or a secondary disease? If it is a secondary disease, treat the secondary cause. If it's a primary disease, then we are left with immunosuppressants. So, in milder form, focal and segmental necrotizing glomerulonephritis. In severe form, there is diffuse proliferating glomerulonephritis and rapidly progressive glomerulonephritis. You are well familiar with rapidly progressive glomerulonephritis, but what is diffuse proliferative glomerulonephritis? It is just uh, the mesangium, the endothelial cells, the epithelial cells all undergo proliferation. All of the three things undergo proliferation in a diffuse manner, not a focal manner, in a diffuse manner in whole of the kidney. Rapidly progressive glomerulonephritis involves proliferation of the epithelial cells of the parietal layer of Bowman's capsule. Diffuse involves proliferation of the visceral epithelial cells, visceral epithelial cells, mesangium, and the endothelial cells of the glomerulus. Is that clear? They're not the same entities. No. Immunofluorescence and electron microscopy show glomerular immune deposits that later migrate subendothelially. Lupus nephritis. Lupus nephritis, or SLE, it affects the kidneys. See, this is what the kidney looks like under the microscope, and there are so many changes there. So many changes. What changes are those? It hasn't spared anything. Do you see? This is distal convoluted tubule. It has affected distal convoluted tubule. It affects even the proximal to some extent. And the glomerulus, largely it affects the glomerulus. 50% of the patient of SLE have lupus nephritis. So that is a very big number. Half of the patients have SLE have lupus nephritis. Immune complexes are deposited in the glomeruli, tubular cells, proximal and distal, peritubular capillary basement membrane, large blood vessels. How you will remember all of those four entities is very simple. Think of immune complex deposits in the blood vessels. And the blood vessels include glomeruli, peritubular capillary basement membrane, right? Peritubular capillaries and large blood vessels. So it is the glomeruli, peritubular capillary basement membranes, and large blood vessels. Tubules are not spared as well. So in the end, you can say tubules are involved as well, right? 50% of SLE patients have thrombi in glomerular arterioles and arteries. So it is throwing thrombi because thrombi are associated with antiphospholipid antibodies. Because of antiphospholipid antibodies, there are thrombi in all the capillaries, glomerular capillaries, arterioles, and arteries. So this is the whole apparatus, and there will be thrombi everywhere. There are 5 patterns of kidney involvement in case of SLE. 5 patterns of kidney involvement. Minimal mesangial class 1, which means there is a little bit of proliferation in the mesangium. Where is mesangium? Here. A little bit of proliferation in the mesangium, and that mesangial proliferation is very little. Mesangial proliferative class 2, then there is focal, then class 2 is slightly more proliferation, focal proliferative class 3, diffuse proliferative class 4, and membranous means the lamina densa. Membranous is class 5, right? And if there is membranous pathology, you don't call it as lupus nephritis. You have to have other criteria to diagnose SLE first. and then see if the kidney is getting involved secondarily because of the SLE. So those patterns are not specific for the lupus nephritis. So what is specific for the lupus nephritis? Antiphospholipid antibodies. Focal proliferative, which was class 3. Focal proliferative. You can see focal proliferation here. Diffuse proliferative, class 4. 30 to 60% of the patients, they fall in class 4. Entire glomerulus is affected, but segmental lesions may also occur. Less than 50% of class 3 are, and more than 50% are for the class 4. That is unfortunate. More than 50% fall into class 4, right? And less than 50% fall into class 3. So advanced lesions are more common. Lupus nephritis class 4, glomerular capillary walls are segmentally thickened by wire loop deposits. Segmentally thickened in class 4 by wire loop deposits. Intraluminal deposits form hyaline thrombosis in capillary. These are hyaline deposits. Intraluminal deposit forms hyaline thrombus in one capillary, and there is global endocapillary proliferation. The whole of the glomerulus undergoes proliferation, that is global proliferation. So you will see thrombi, global proliferation, and thickening of the capillary loops. Thickening of the capillary loops is called wire loop. Right, thickening of the capillary loops is called wire loop. There is thrombosis in some of the capillaries, that is called as hyaline thrombosis. There is wire loop thickening of the whole of the capillary wall, and then there are intraluminal deposits. What happens in this is the same. This is the same. You can appreciate wire looping, right? And some of the capillary will have thrombi in them, and there you can see some of the haziness globular deposits in the proximal convoluted tubule. Diffuse proliferative, the whole of this glomerulus is involved, and the entire kidney gets involved as well. This is membranous glomerulonephritis. There is irregular thickening and rigidity of capillary walls accompanied by global mesangial hypercellularity. There is hypercellularity of mesangium. Hypercellularity of mesangium in this case is not accompanied by immunological deposits or immune deposits in this mesangium. So no immune deposits in the mesangium means it is not IgA nephropathy, right? So it is mesangial proliferation accompanied by a lot of other things, glomerular wiring, wire loop like things, and we have got glomerular wire looping, and we have got thrombi in the blood vessels. We have got so many thrombi in the blood vessels, right? Immunofluorescence, antibody and complement, they have granular deposits. This is what lupus nephritis kidney looks like. Immune complexes are present by electron-dense deposit in the mesangium, intramembranous, subepithelial, or subendothelial location. Immune complexes are present as electron-dense deposits in mesangium, intramembranous, subepithelial, or subendothelial location. What was spared? Was there anything spared? It has thrown immune complexes everywhere. Subepithelial, subendothelial, intramembranous means in the lamina densa, lamina rara, externa, lamina rara, interna. What was spared? Mesangium. Nothing is spared. So SLE has thrown immune deposits everywhere, and it has caused this picture, right? Even this picture is the same, but you will see immune deposits everywhere. Mesangium, intramembranous, I think that is easy for to remember. I don't have to keep repeating. Subepithelial deposits, subendothelial deposits. This is the nucleus of the endothelium, and there is a huge subendothelial deposit. Porocyte foot processes have undergone effacement as well. These are the porocytes. And look at the foot processes. There are immunological deposits that have caused effacement of the foot processes. And double contour occurs in which disease? Membranoproliferative glomerulonephritis. When there is a new membrane thrown above the, or new membrane is, you can say, new glomerular basement membrane or lamina densa, dense layer is formed above the immunological deposits. So it is that disease. Variable amount of mesangial deposits are there. Membranous lupus nephritis, subepithelial class 3 and 4, subendothelial class 1, 2, and 5. When you see subendothelial deposits alone, then you call it class 1, or it is class 2, or it is class 5, depending on other features. If there is subepithelial deposits, then it is class 3 or it is class 4. And in membranous, there are deposits everywhere. Membranous just means lamina densa. Wire loop lesion, focal and diffuse proliferative class 3 and 4. Lupus nephritis, they reflect active disease. Wire looping shows that there is active lesions, or there is ongoing pathology. Tubulointerstitial lesions, discrete immune complexes similar to those in glomeruli are present in tubular or peritubular capillaries. So we have talked a lot about the glomerular lesion in SLE. Now we come to the tubulointerstitial lesions. In tubulointerstitial lesions, we have tubules and we have capillaries. There are immune deposits in both of them. And immune deposits are so many immune deposits everywhere. It will cause hematuria, proteinuria, hypertension, severe renal insufficiency. Those are features of nephritic syndrome. Hematuria, proteinuria, hypertension, azotemia, and oliguria, mild to severe renal insufficiency, right? Mild to severe renal insufficiency, oliguria. Anuria, no urine, oliguria less than 400 ml per day. Polyuria, more than 3 liters of urine per day. Amyloidosis, why does amyloidosis happen? Because there is some pathology in the kidney that lives for a very, very long time, or you can say that the body is somehow unable to come out of. Pathology that stays there for a very long time are, in case of infections, it is tuberculosis, that even when we treat it, it lives at least for 6 months or 9 months or even more, 12 months. But there are diseases like arthritis that almost like osteoarthritis or even rheumatoid arthritis that stay there forever. And in staying there forever, what the problem is that when they initiate an immunological reaction, they cause a protein formation that is not going to get digested. This protein is amyloid that is not going to get digested because we don't have the enzymes for them. And when these proteins are thrown into the kidney, they are thrown everywhere in the body. So it is a generalized body condition, not specific to the kidney. But when they are thrown in particular to the kidney, what they do is obliterate the kidney, the urinary space, and they don't recognize any boundary. They're thrown everywhere. Kidneys are normal in size and color. In advanced cases, they get shrunken, atrophied, right? Shrunken because of ischemia, vascular narrowing, deposition of fat, amyloid in arteries and arterioles. Primarily, they sit in the glomeruli because glomerulus again is a filtration area which is a higher pressure area that filters all the waste stuff, and it gets affected by these toxic material more easily and quickly. Primarily in the glomeruli, interstitial peritubular arteries, arterioles are also affected. So in interstitium, peritubular arteries and arterioles get affected, and there is subtle thickening of the mesangial matrix, right? So what happens? There is thickening of the mesangial matrix, uneven widening of the basement membrane of the glomerular capillaries, which means thick and thin membrane, capillary narrowing, distortion of the glomerular vascular tuft. In advanced diseases, obsolete glomerulus is flooded by confluent masses of interlacing broad ribbons of amyloid. The glomerulus undergoes sort of all amyloid deposition. There is it is flooded by the amyloid, which means you see nothing but amyloid. The glomerular capillaries eventually disappear. There is nothing but amyloid. They are flooded by the amyloid. There is a lot of amyloid that is going to sit there and damage the capillaries. And initially, the kidney will be of normal size, but as the disease advances, it will get shrunken. It will get atrophied. Uh, you see this another feature, uneven widening of the basement membrane of the glomerular capillaries. Do you remember thin and thick areas of the basement membrane in any other disease? It was Alpert syndrome, right? But there was immunological deposits in the Alpert, were there? And it was basket weaver-like membrane. In this case, it is not like that. It is just the thin and thick basement membrane, widening of the basement membrane, and there is flooding of the glomerulus by this confluent masses or interlacing broad ribbon of amyloid. There was nothing of the sort in Alpert syndrome. Instead, Alpert syndrome had other three features. This is ribbon-like deposit of amyloid. Look at this. It has flooded the glomerulus. Special stain, Congo red, apple green color. Right? So the name of the stain is Congo red. And what will it show? It will show a green color. And that is a bright green color. So we call it as apple green color. This is the bright green color, and that is called as an apple green color. Chronic glomerulonephritis. Yes, that is favorite for all of us because whenever we call chronic glomerulonephritis, it is not a single disease entity. When kidney starts failing, it will enter into something called chronic glomerulonephritis. Pool of end-stage glomerular diseases that is fed by several streams of specific type of glomerulonephritis. There's a lot of diseases that will come into this entity. So I think that is all done with, we are all done with the glomerulonephritis, right? Now we come to the tubular problems. So we have ended our glomerular diseases. We have glomerular diseases, and then we have tubular diseases, in which we will study the acute tubular necrosis as well. And there are infections in the tubules. There are stones in the tubules. Stones are formed in the tubules, thrown into a larger collecting ducts, into the papilla, thrown down into the ureter, and we call it as either ureteric tubule as long as they sit in the collecting duct, or still somewhere in the parenchyma of the kidney. We call it as Kidney stones. All of us are familiar with renal pain and kidney stones. We have seen people suffering from such a thing, so it's a very, very common entity. Pyelonephritis, urinary tract infections, they are actually very, very common. We have some specimens in our lab that have got large unsymmetrical cysts. Some cysts are very big, some are small, and some of those cysts are so big that they have destroyed almost the entire renal parenchyma. If that happens, kidney doesn't function. So you don't leave any disease untreated in the kidney. Like all other infections, it could be acute or it could be chronic. For chronic, the reason why the pyelonephritis was initiated has to live there for a very long time. So pyelonephritis affected tubules, interstitium. It affects tubules, interstitium, and renal pelvis. In the kidney, we have tubules, interstitium, and renal pelvis. Why did we exclude the Bowman's capsule? Because we have glomerulonephritis for that. So it is not glomerulonephritis. Pyelonephritis is everything below the glomerulus. It is tubules, interstitium, and renal pelvis. Most common disease of the kidney. Then we have acute and chronic. In acute condition, it is just the bacterial infection. Bacterial infection can be because of some blood infection, like we can say septicemia, right? Or it could be because of bloodborne, or it could have been introduced from outside. If there is a stone, it has injured the kidney. It will also cause bacterial infection. And chronic pyelonephritis. In case of chronic pyelonephritis, when the infection either reoccurs, it is episodic, one after the other infection, it keeps coming back, or there is a reason for it, like there is an obstruction in the tubules or somewhere in the renal pelvis, and the infection just comes back again after treating it. Vascular reflexes are because of valves in the abnormal valves in the ureter. The affected bladder, cystitis. Whenever the bladder gets infected, it is called cystitis of the urinary bladder, or cystitis is good enough. The kidneys and their collecting system are pyelonephritis, right? Infection of the bladder is cystitis. Infection of the kidney and their collecting system is pyelonephritis, right? So it could be only pyelonephritis or pyelonephritis and cystitis, because if bacterially infected or infected urine is coming or thrown into the bladder, so the bladder might get infected as well and will form cystitis. What happens if the bladder gets infected? It will show signs of irritation, which is it will have more frequent urine formation. So hematogenous infection will come from the blood. Right here is the blood, and it is staphylococcal and E. coli. Right, E. coli is one common organism that can be introduced from ascending infections from the blood, or from the descending infections, or from the ascending infections. Ascending infections mean from the ureter up, which means that if there are incompetent valves, vesico-ureter reflex, then also E. coli infections are quite common. In fact, E. coli is the common most in ascending infection. And then it is Proteus, and then there is Enterobacter. Those are very difficult to remember. No, there is I feel like you know these things from before. Pyelonephritis, it could be ascending, it could be descending, so it is simple, not as difficult as glomerulonephritis. Look at this. This is a cystogram. Vesico-ureteral reflex demonstrate avoiding cystourethrogram. Inject the dye, and then you see the kidney functions. And then it causes vesico-ureteral reflex. Look at this. ureter, right? This ureter is very dilated. It's a wide ureter, and dye injected into the bladder reflects into both the dilated ureters, filling the pelvis and the calyces. It is going upwards. Acute pyelonephritis, patchy interstitial suppurative inflammation is there. Focal abscesses are there that can be of wedge-shaped. Intratubular aggregates of neutrophils because it is acute infection, right? In acute infection, you get aggregates of neutrophils. Tubules undergo necrosis, and glomeruli seem to be relatively resistant to infection in the later stage, but they do get infected and they do catch the same infection eventually. But initially, they seem to be resistant, but they do get infection. What is there abnormal in this kidney? What abnormality do you see in this kidney? These light areas are abscesses. This is pus oozing out of the kidney. All of this is pussy, right? Look at the histology. You see this? So if you concentrate here, you see one, two, three. Either it is bilobe nucleus or it is trilobe nucleus. It is bilobed or it has three lobes. These are neutrophils. So there are a lot of neutrophils. Either these neutrophils, you could see those neutrophils as a whole, or you can see sludge of cells, which means broken cells, right? So this is these are some broken cells, and this is a picture of abscess. This is plasma cell. Looks like a macrophage. Papillary necrosis. Diabetics are more prone to papillary necrosis, and obstructive uropathy patients, patients who have obstruction because of some external cause or internal cause. Internal could be stones or a tumor, external causes could be pressure from outside. But papillary necrosis is usually bilateral, right? Tips or distal two-thirds of the pyramids are affected. Coagulative necrosis occur. Leukocyte in response and leukocytic response is limited to the junctions. Pyelonephrosis and peripheral abscesses there. Pyelonephrosis or peripheral abscesses there. There are multiple abscesses here. 1 and 2. This one is, these are the two abscesses. Those are pyramids. This is, it looks like flowing out from here. So pyelonephrosis, perinephric abscess. Perinephric abscess is not shown in this diagram. Perinephric abscess should have been here, right? Something, when abscess appears here, that is perinephric abscess. So pyelonephrosis is this one. Scar, if the disease is bilateral, where should the scar form? It should be bilateral. Almost always associated with inflammation, fibrosis, deformation of underlying calyces and pelvis. Tubules will undergo atrophy. There will be interstitial fibrosis and lymphocytic infiltrate, patchy jigsaw pattern of intervening preserved parenchyma, which means between the lymphocytes there is normal parenchyma. In between these lymphocytes, you can see a normal tubule, and here you can see affected tubule, then there will be a normal tubule. So in between the affected area, there are normal areas. Interstitial fibrosis, lymphocytic infiltration, patchy jigsaw pattern with intervening preserved parenchyma. These are causes of papillary necrosis, could be diabetes, analgesic, sickle cell, and obstruction. Do you remember SODA? SODA, right? Diabetes, analgesics, sickle cell, and obstruction. infection. This is just to give you an idea of how common things are in males and females and the time course when they develop the papillary necrosis. Diabetes 10 years, analgesia is much earlier, right? Infection, 25% of the cases of infected people get papillary necrosis, but 80% of the causes it causes in diabetics get papillary necrosis. Calcification is frequent in analgesic nephropathy, right? Number of papilla affected is almost all at different stages of necrosis in analgesic. Analgesics really play a havoc in the body. Predisposing conditions. We have only 3 minutes left, I think, and we are almost done with this. Yes. So we can complete this. Predisposing conditions, urinary tract infection, instrumentation, vesico-ureteral reflex, pregnancy, gender and age after first year of life in around 40%, pre-existing renal lesion, obstruction, scar, and diabetes mellitus, immunosuppression and immunodeficiency, kidney allograft when they get infected with polyomavirus. Poliovirus, polyoma virus, they get this infections, pyelonephritis. There are several lymphocytes here. Clinical features, sudden onset, because in cases of acute onset, it is always sudden. Pain at costovertebral angle. And how do you examine it clinically? By a thumb in the costovertebral angle. If it is pain if somebody says I have a back pain, then you give a thumb at the costovertebral angle to see if it is kidney. Systemic evidence of infection, fever and malaise, dysuria, frequency and urgency. Painful urine is there. Patient passes urine lots of time and he feels that the urine will spill out if he doesn't pass urine. You may see white color urine, pyuria, pus in the urine, leukocytic cast, which pus comes out. If there are casts, it means that the cells have undergone some modification in the tubules and they are thrown as cast. Then there is quantitative urine culture. You can do culture to see which kind of organism is affecting and what kind of antibiotic will be beneficial. In uncomplicated cases, there is benign course. Symptoms disappear within a few days after institution, after giving the right kind of antibiotic, but it will reoccur as a new case if there is some reason to develop infection again. Right, there are a lot of reasons. Unrelieved urinary tract obstruction, diabetes or immunodeficiency, repeated systemic episodes, acute renal failure, and papillary necrosis occurs. Thank you very much for being patient listeners. If I had a few more minutes, I could revise the whole thing. But today, I think the glomerulonephritis portion was quite simple. And the second lesson of ours was this pyelonephritis that was also quite simple. It was not difficult to understand. If you read it yourself, I think you can make it very well. You can understand it very well. So next we will do renal tumors, and along with the renal tumors, we can do some renal cyst as well. Okay, Allah Hafiz, and bye for now. Is there anything you have to say, Hussein? Yes, Hussein, do you want to say anything? Nothing? Okay, there's nothing in the chat box. So I'll just leave you.